Hello, dear colleagues and friends. I'm Dr. Claudia Pinter, orthodontist from Austria, Vienna. And today it's about adult skeletal maxillary expansion, how-to for dentists and orthodontists. For far too long, we have accepted that this process involves aggressive surgery and is disfiguring in the process. At least this is the feedback that I receive from my patients. So you will be interested to hear what novel approaches we have to make it minimally invasive by using a bone-borne expander, using a patient-specific expansion protocol to tailor to the needs of our patients, and how to keep the process aesthetic by keeping front teeth aligned, avoiding a big diastema, big gap between front teeth to open up. Let's start with the why. Indications for skeletal maxillary expansion is a transverse deficient maxilla. So that could present with a crossbite, but also without crossbite. And those are the interesting cases because often when we have a transverse deficient maxilla, the patient also presents with impaired nasal breathing. You can simply find it out by asking, hey, how's your nasal breathing? Can you breathe through your nose properly? Do you snore at night? Do you sleep with the mouth open? Because the roof of the mouth is also the floor of the nose. So especially, I want to challenge you, in cases where you have a narrow maxilla but no crossbite, evaluate nasal breathing. Maybe you can do more for the patient than just a great smile. Other indications are maxillary protraction, for example in a class 3 case, but we're not going to talk about that. Let's face some hard facts. In adult patients, the mid-palatal suture is highly interdigitated. It's fused. Therefore, extensive osteotomies, level 1 osteotomies, are necessary, basically where we separate the maxilla from the skull so we can expand. A tooth-borne expander is used to separate the maxillary halves. As a result of the rapid expansion, a diastema occurs, a gap between front teeth, which is later closed with braces. This treatment option is often a bitter pill to swallow for our patients. That's why it's not surprising that a lot of patients reject that kind of treatment, even though they're aware of the health benefits. And this is a problem, because if we cannot address the root cause, the discrepancy in the jaws, the result will always be a compromise. So why we cannot change the facts, we can solve the problems. So in adults, the mid-palatal suture is fused, that's a fact. But the extensive surgery with level 1 osteotomies, we can reduce the invasiveness by using a bone-borne expander, meaning we anchor in the bone with the expander, not on the teeth. And like that, just minimal cuts are enough to achieve separation of the maxillary halves. So let me introduce you to DOME, distraction osteogenesis maxillary expansion. This concept describes how we turn a high-arched palate into a dome-shaped palate. In a high-arched palate, the tongue doesn't have enough space to rest where it's supposed to be and usually presents with a crossbite, and the aesthetics are also impaired. However, in a dome-shaped palate, the tongue can rest where it's supposed to be, increasing the pharyngeal airway. Also, the jaws fit together nicely and to create optimal aesthetics. So with DOME, we use a bone-borne expander to allow minimally invasive osteotomies. The patient-specific expansion rate is therefore possible because we do not use teeth as anchor, but we're anchored in the bone. For example, that would be 2 turns per week instead of 2 turns per day. And DOME XT, the latest innovation, means dome without diastema. So the aligners keep the process aesthetic. As we expand the maxilla, the aligners keep the teeth together. Here is what is critical for success of the bone-borne expanders. When we want to anchor in the bone, we need to have the screws placed in the bone. And the maxilla just has very limited spaces where we can place those screws. So 2 screws need to go into the anterior palate. The anterior palate, that would be here behind the third ruga. Why? Because this is the only location where we have the best conditions to insert mini screws. For the 2 posterior screws, you need to look for bone. So usually you would find good bone in the areas that are yellow in that little cartoon. For example, between the roots of the 6 and the 5. So for the anterior screws, you will take a 2 diameter, 9 millimeter length screw. However, for the posterior screws, if you place them between the roots of 5 and 6, the soft tissue is a lot thicker there. That's why you need a longer screw. 2 millimeter by 30 millimeter is a good choice. And this is how the clinical implementation would like. So you place the screws, take a scan, you order an expander, and you insert the expander. If indicated, you send the patient to the surgeon who does the dome osteotomies. And then in the meanwhile, you plan the aligner treatment. So give the following instruction to the technician. You order a setup where you correct the crossbite or where you expand until you have ideal occlusion. And you give the technician the instruction to reduce the speed by half. So that would be 0.1 millimeter buccal movement per aligner. After 4 weeks of healing after the surgery, you insert the aligners and instruct the patient to turn 2 times per week and change the aligners on a weekly basis. Like that, you do the heavy lifting, the orthopedic expansion of the maxilla with the bone-borne expander, and the tooth movements with the aligners. Because we're going for a very slow expansion protocol, we can simultaneously move the teeth into the area where the new bone is formed. If you want some practice before you do that in a patient, I recommend the Fellowship in Advanced Aligner Orthodontics. This is where you do exactly that procedure in a mannequin head. So here, the anterior screw is placed behind the third ruga. This is the best insertion site. And you can see it's really not a big deal. Of course, the patient would be anesthetized and wouldn't feel a thing. You place your 4 screws and then you take a scan to order the custom-made expander. This treatment approach has changed for me dramatically the acceptance rate of skeletal maxillary expansion. While before, with the aggressive surgery and the tooth-borne expander, maybe 20% accepted that treatment, that has gone up to 80%. But the best thing about that treatment approach is that we can improve our patient's health beyond the oral cavity. Because if you look at the anatomy, the nasal cavity is embedded in the maxilla. So if we expand the maxilla, we also widen the nasal floor, making it easier to breathe through the nose for our patients. If you want to learn more about that, I recommend the Fellowship in Aligner Orthodontics. It's an online course with live hands-on training. So you do the procedures on a mannequin, you're supported with a lot of lectures, and you have a full year of mentorship, meaning that experienced orthodontists guide you in your journey of implementing new knowledge. I'm happy to provide you with a discount code where you save 15%, so that is around $1,000 US. Don't miss it, it's RIPE Claudia 15. If you're interested in a more tailored solution, Dr. Stanley Liu and I offer expert clinical advice. So we guide you in your treatment when you want to expand your patients. We help you with diagnosis, treatment, planning, and execution. I hope this was helpful, and I'm looking forward to your feedback or just to connect with you. So reach out to me on Instagram. That's DR for Dr. Claudia Pinter. Thank you.